I'm going to be talking about the diagnostic challenges and gaps that we have when delivering care in developing countries, particularly. So just to revise why we need diagnostics, we need them to get an accurate diagnostic of a disease, which enables a specific and timely treatment to be provided to the patient. It ensures that the treatment is successful because we're only treating the right disease. It reduces the development of drug resistance, and it improves patient and prescriber confidence and satisfaction. We also need diagnostics to do disease surveillance so we can understand the epidemiology of diseases, which enable better public health interventions and improved disease control. We need to look at what are the characteristics that we need in a good diagnostic tool. And we can see that we need accurate results, so they have to have high sensitivity and specificity, even when there's a low prevalence. They need to be set at a level of detection which will identify the actual cause of the disease, but which could pick up asymptomatic or low-density infections. We need the results to be rapid, especially when the patient is severely ill. They have to be low cost, both to the health system and the patient. They need to be robust and easily maintained. They need not to be reliant on external power supplies, and they need to be easily trainable for health workers to use them and properly interpret the results. We need to have in place good quality control systems to ensure that the results are accurate, and we need them to be able to be stored and distributed. We need to have a long shelf life, for example, not necessarily to have cold chain, and to not be affected by temperature, humidity, and dust. Who needs these diagnostics? So health workers at all levels of the health delivery systems need diagnostic tools which are adapted to their particular place of work. For example, CHWs need simple to operate, robust, low-cost tools which give rapid results and which can be easily included in diagnosis and treatment algorithms, which they already have, like IMCI or ICCM algorithms. They need to know which cases can be managed safely in the community and which should be referred to a higher level health facility. Health workers at the first level health facilities also need diagnostics that are accurate and that can drive their treatment. Their treatments. And in most lower level health facilities, there are no formal labs, but they need to know that they can send a patient 15 kilometers home safely and that they won't die on the way or when they reach home. And hospital health workers in the developing world have access to labs of very many different levels of sophistication, but lab technicians are often in short supply. They're overloaded with work, making the provision of timely results a problem, and they don't often supply a 24-hour service. So this is a picture of a community health worker working in her village, and this is the sort of way she has to work. So we know that most of the healthcare in developing countries is delivered in these kind of settings. So again, they need their tools to be simple, low cost, and give rapid results. And they also need to fit into the diagnostic algorithms that they already use. And they also need to know when to refer patients. So to just put in some of the challenges and gaps we have. So we need to ensure that the diagnosis is a quality diagnosis. So we might need more sensitive diagnostics, especially in countries which are trying to reach pre-elimination and elimination status of various diseases. They should be simple to use, but you might need more sensitive rapid diagnostic tests for malaria, for example, than current brands that can pick up lower density parasitemias. And the quality of the malaria diagnosis is difficult for community health workers who may have vision problems. They may be colorblind. They may be old like me and not able to see the lines on the RDTs. So actually digital reporting tools can be made available at community level that could read the RDTs, for example. And microscopy is being superseded by RDTs in many countries, and that's a problem, and skills in microscopy are being lost. Quality assurance and quality control systems are often very weak, affecting the reliability of tests, especially those most used in the peripheral health systems, such as RDTs. And so when you're thinking about introducing new diagnostic tools, please think about the quality assurance and quality control systems that need to be implemented alongside the tools, and that storage and distribution systems are adequate to preserve the efficacy of the tool. So when a poor community health worker is in her community or his community, there are certain things they need to know about a fever. What's the causal organism? Is it a bacteria or virus for a start, in case they need to prescribe an antibiotic? So they need to know, will the antibiotic work? Is it the correct one to use for that? And are there co-infections that might be causing the fever? If it's a viral infection, what virus is it? Because most of the viruses have very similar presenting symptoms. They also need to know whether they can manage this at home or they need to refer it to a higher centre. Another dilemma, particularly around malaria, is when the fever is vivax malaria, can they safely deliver a radical cure? And therefore they need to know how they can use G6DP deficiency testing, because the testing that's available at the moment is only really useful at the health centre level. Again, should they include other RDTs which are already available for such febrile causes as dengue, leprosy, leishmaniasis, HAT, and SARS-CoV-2 are obviously at the moment? Is the test good enough? Is the sensitivity and specificity adequate to guide the diagnosis? Is it easy to determine the result of the test? And we need to develop new algorithms for interpretation of these multiple test results. And do we need RDTs for other conditions like diarrheal disease or Helminth's diseases? And can we improve decision-making about referral by assessing severity of disease, for example, introducing the use of pulse oximetry or anemia quantification? And for the hospital worker, they are dealing with a much more complex situation, which is the physiological situation of the patient as well as the actual cause of the disease. So the diagnostic tools have to include the causative organism, and whether there are more than one causative organism, but also the physiological status of the patient, which would include full blood count, liver function tests, acid-base balance, etc. And all such tests need to be fitted into the diagnostic algorithms to guide a comprehensive treatment. And at a hospital level, using the right drug is even more important. So diagnostics for evaluation of antibiotic or antimicrobial sensitivity profiles for these kinds of patients are needed to support therapeutic decision-making. So these are just some of the challenges in the diagnosis when diagnostic tools, when they're introduced at different levels of the health system. So that's the end of my presentation.